a moment to join. Let me just check for this particular panel on looking at NIMHANS 2 as well as the strengthening of the facilities in the Northeast. I just want to make sure all our panelists are here before we formally start. I just hope that you'll all put on your video cameras. So may I just check that Dr. Ashok Babu is here, please? I request Dr. Kaustubh Giri to just check if he's going to join in.
Ma'am, Ashok Babu sir, I just contacted. He said he'll be joining in 5-10 minutes, ma'am.
In 5-10 minutes. That's fine. Just advise us, Dr. Giri, as to when we should start. Should we start immediately or should we wait until 11 o'clock to start?
Ma'am, I believe we can start, but we can start after 5 minutes, ma'am. We'll let.
We start in 5 minutes.
Yeah, 5 minutes later we can start, ma'am.
So thank you. I think a short break of 5 minutes to kind of get ourselves together, maybe get yourself a cup of coffee, and then we will start the session in 5 minutes.
Transition, there is also a disease burden shift which is happening with increasing non communicable disease burden, which requires diagnostics, imaging, pathology, rehabilitation, and behavioral health and long term care. Most importantly, long term care. So, this is coupled by there has been a growth in healthcare infrastructure. So, we have 70,000 plus private hospitals, 1.5 lakh labs, and 30,000 imaging centers. So, they also require skilled professionals to run. There is an increasing adoption of technology with MRI, CT, molecular diagnostics, genomics becoming part of the treatment protocol that we have. So, all of this requires trained technologists. Also, the national public health mandates that we have require expanded teams of physiotherapists, lab technologists, optometrists, counselors. There is a whole array which of professionals which is required. So there is an unfulfilled demand. And academic studies also indicate a shortage of allied healthcare professionals, unfulfilled demand across various allied categories, with acute shortage in trauma care, rehabilitation, and medical laboratory across the major professional categories. So, the priority list to begin with is these are the professions that we're looking at. As I've written, this is the priority list to begin with. This does not mean that we will not be covering other professions, but to begin with the limited resources and based on the studies that we could find, and also the fact that these are the professions for which NCHP has finalized the course curriculum. These are the professions which have been, I would say, identified to begin with when we start implementing uh, the budget mandate. While all these things are happening, it is also a fact that there are institutional gaps. We have 500 government AHP institutes having around 48,000 seats and around 3,800 private institutes with 3,63,742 seats across various disciplines. So, as you would be seeing, and as all of you would be aware, that most of the capacity for the allied healthcare professionals, their education rests with the private sector as of now. And we find that there is a significant variation across institutes in their physical infrastructure, laboratories, equipment, trained faculty, and other facilities. So this inconsistency then affects the workforce readiness and national standards, which are being laid by NCHP. So, what are we expected to discuss in the discussions that we have? We are going to look at how can we expand the available resources to increase seats in these priority AHP disciplines at the diploma, UG, and PG levels. How can we modernize government AHP colleges with quality infrastructure in line with NCHP norms, standardized laboratories with the equipment, simulation centers, at the same time, mitigate the shortage of quality trained allied health faculty in educational institutions. And most importantly, create awareness about the opportunities and the employment opportunities that this sector presents. And if you would recall, the Honorable PM in his speech said the youth has aspiration. Youth has aspiration for better life, better opportunities which are available for them to earn livelihood. And this sector is one of those which can offer this to our youth in the coming years. So, what do we expect from our esteemed panelists is that we expect to get structured feedback from you so that we can take back your inputs and translate them into policy action when we are formulating a scheme. We would also like to hear your comments on the present situation and what is the demand of allied healthcare professionals in various fields in job markets that you see in times to come. We would also like you to identify what are the practical challenges that you see as in terms of the infrastructure, faculty, training capacity, and employability of AHP graduates. It would also be good to hear from you on what are the awareness and outreach activities we should undertake, considering the low awareness about AHPs and the career opportunities which are there. And most importantly, we would also like to hear on the potential partnership avenues in public, private sector for allied health professions, financing, student training, internships, scholarships, any other suggestions that you have. Um, Thank you. So this is the short presentation that I had from my side, and we are eagerly now, going to look forward to hearing from you. And let me first begin with Dr. Yagna Shukla, ma'am. Um, Ma'am, as you know, the regulatory landscape for the allied health education has undergone a transformative change with the establishment of NCHP. You have launched a standardized competency-based curriculum for 15 disciplines. So keeping in view the ambitious target of the budget announcement, uh, according to you, what regulatory pathways can help us in achieving this goal? Ma'am, you have the floor.
Thank you very much, madam. Am I audible? Thank you. Very good morning and namaskar. Respected Dr. Vinod Kotwal, madam, distinguished panelist of post-budget seminar for scaling up allied and healthcare professionals as per para 53. First, on behalf of allied and healthcare professionals and NCHP, I would like to sincerely thank our Honorable Prime Minister Sir, Honorable HFM Sir, Ministry of Health and Family Welfare, and Ministry of Finance and Corporate Affairs for announcing the budget for allied and healthcare professionals, which was much needed aspect to be taken care of. So thank you very much. As you all know, NCHP is the largest commission of allied and healthcare professions, and it as a part of one of the objectives of this NCHP Act is standardization of education, and on that basis NCHP have released 15 curriculum which are competency based and which is covering 25 professions so far. And soon 2 more curriculums are also going to be released, which will cover 28 programs scheduled under this act. And as a One Nation, One Curriculum program from 2026, this all curriculum are to be implemented all over India, and I am very happy and that all the states, they all are ready for the implementation of this curriculum. Now, as far as curriculum part is concerned, that is all set. As far as minimum standards for institution is concerned, the regulations are already being drafted, looking at the practicality and realistic view. And soon, even that process will be over. Over and above this, the registration part is also on the way of finishing, and soon we are starting registration of these allied and healthcare professions. So, as far as upgrading the existing institution as per the budget announcement and starting new programs are concerned, and increased number of seats, we have done some homework of all the states, and we had asked the information, and we could gather around of information of about 33 states. Of course, unless and until we have registration, we will not be able to know exact number. But if we consider this number, then as Madam rightly said, the government institutions are hardly 550, and versus private, including government aided institutions, are around 4,000. And government institutions have around 48 to 50,000 seats, versus private institutions have around 4 lakhs seats for the allied and healthcare professions. So, looking at this observation, we can make out that we need to strengthen, upgrade, and we need to have more number of seats in the government institutions, because I think that will take care of so many other aspects, including fee structures. The students will have a benefit of fees also, because it will be under the government institutions. So that was a humble suggestion as well as submission, that we must have a more of government institutions. Over and above this, one more observations we have found, that there are many programs which are not being run in many states. So it is not like all 57 programs are being run in all states. So from that angle also, we need to take a call that wherever there are no programs they are being run in any states, we must encourage that programs, and we must see to it that those programs are being covered in that states, which will strengthen the healthcare sector of that state also, and which will increase the capacity, as far as capacity building of professionals are concerned. That will also help. The most important thing I would like to suggest here, madam, is that if we are targeting medical college campuses to have more programs, whether it is government or private, but that will have many, many more benefits of resources, using the resources of faculties, using the resources of clinical exposures, because all these programs, except biomedical technology, which is a non-clinical program, they all require clinical exposure, which is mandatory. And that will be available very easily in the medical campus. So, and as this being a healthcare program, basic subjects of medical, they are going to be mandatory to be taught. So we can take advantage of medical faculties. So that way, the faculty part is also being taken care of. So if we look at the medical campus, and if we consider of having new programs or increased number of seats, or starting, as I said, and upgrading the existing institution. I think this is a very important point to be taken into consideration. So, this, I think, looking at this government institutions to be strengthened, the kind of programs, if it is not there, because this is a very serious observations in the states where they are not finding some professionals even for their local, state council, because they don't have such programs in that states. So I think that angle is to be taken care of. And main thing is having a program in a medical campus rather than in a technical campus, because this clinical exposure is very much mandatory and needed, which is a base of this education program. So that was regarding this regulated landscape for allied and healthcare as far as curriculum part is concerned. As far as awareness of this program is concerned, yes, it is a very good observation in the sense that there is a lack in awareness of programs in certain disciplines. As far as physiotherapy, optometry, medical lab science is concerned, I think there is this issue is not there, but in other programs there is a lack in awareness of this disciplines, and for that the humble suggestion from this NCHP would be that we can create a national awareness campaign highlighting the diversity and importance of allied and healthcare professions through digital media, public messaging, and collaboration with healthcare institutions. Another suggestion would be, which is really very, very important, that if any collaboration is being done with the Ministry of Education and State Education Board to integrate information on allied and healthcare professions into school career counseling programs at a secondary and senior secondary levels. So I think, madam, that will help us a lot in creating this awareness, and we can develop a centralized national allied and healthcare portal providing information on recognized professions, accredited educational pathways, competencies, and career opportunities. I think that will also help in creating awareness. Again, this NCHP also can help in this. We can have a career guidance manuals. So that can be in a soft copy, if that can be kept on a website. So indirectly, if it is easily available, I think that can also help in this creating awareness. And at the same time, the programs, as I said, there are programs which are not there in certain states. If those programs are being introduced, the institution itself will create awareness about that program. That will also a kind of creating indirect awareness, because once they have this program, they would like to see to it that that program is being available in that state, because unless and until the program is not available in that state, again that can be another issue, because if at all they want to pursue certain programs, but if that program is not available in that state, then they may have to go to another state for that program, which may not be that practical also. So I think, madam,
Yes, ma'am. I think you have in detail elaborated what you think NCHP is going to do in terms of the regulatory pathway, the regulations that you are coming, and we thank you for sharing also your views how to increase awareness about these professions and what you think can be the steps forward. Now, at this point of time, when we are talking about creating these opportunities, it is also very important to understand actually have any numbers or any statistics on the requirement of the allied health professions in different categories. We, from various academic studies and industry reports, we can see that there is a need. However, I would like to request Shri Bhattacharya ji to share with us if what are his thoughts on the requirement, the number of allied health professionals in different categories, keeping in view the disease and the demographic transition that we talked about. Bhattacharya ji, you have the floor, please.
Thank you. I hope I'm audible. Good morning, everyone.
Yes, you are audible. Thank you.
Thank you, Dr. Kotwal. It's indeed very inspiring to listen to Honorable Prime Minister, and thank you for giving us an opportunity to share our thoughts on the allied health professionals' career. As we all know, India today is facing a growing burden of morbidity, mortality from chronic diseases, which really requires an additional well-trained cadre of health professionals to work hand in hand with doctors and nurses to complement their clinical expertise while taking a lot of the patient care delivery growing burden that covers not only the care delivery but also the preventive, holistic, and the clinical side of care from NCD chronic diseases, especially as India becomes today it is the second largest aging population in the world, and it will increasingly the demographic shift will happen. It is therefore very apt and significant that the budget of 2026-27 has prioritized this sector. We thank Government of India and Ministry of Health and Family Welfare for seeking our inputs, how to mobilize this cadre. I will limit my comments to the overall demand that we see from an industry perspective. And we had run a professional survey, not only within NatHealth, but a number of other partner federations to come to these numbers. At a macro level, I will talk about what we see is the total demand for AHP. And then I'll go a little bit into the specific, the 10 competencies that have been laid out under para 53 of the budget announcement. First, India's current overall allied health professional penetration per 1,000 population is a number that is 0.7. And that's a growth of 0.5 per 1,000 population over the last decade. If you really compare ourselves to, let's say, few global other countries, let's say UK, it has 2.2 per 1,000 population. Australia has about 8 per 1,000 population. US has 15 per 1,000 population. If we really juxtapose those numbers to the fact that India has 25% of the global disease burden with about 18% of the global population, and we have a growing burden of NCT, diabetes, hypertension, cancer, the second largest aging population, our requirement for AHPs in India is significantly higher. Significantly higher. I'll just talk about how significant, but let's for a minute say it's very significant. Another very important thing that's happening in India is, as Honorable Prime Minister outlined, the health access in India is opening up fast, and the health-seeking behavior, therefore, across the country is growing by leap and bound. If I have to just take an example of penetration and volumes of pathology tests and radiology tests in the country, that's doubling every 3 to 4 years at the moment. And the total current gap, even within industry, is about 30 to 40% of qualified AHPs, and it will significantly continue to grow just by virtue of the health-seeking population and the access growing. As more and more programs like, PMJY is a massive demand driver. And there are more awareness about health and the fact that, unlike episodic interventions in health, the non-communicable diseases will require frequent usage of the health system, a very different kind of design than what existed even 5, 10 years back. While there are no established population benchmarks for AHPs, it's generally accepted that AHP makes up about 2/3 of the health professional workforce in a matured health system. Thus, if doctors and nurses, for which WHO has standards, and it makes up about 4 per 1,000 as per WHO benchmarks, the India will eventually need, just from that one statistics alone, about 10 million, over 10 million allied health professionals. A number that is conservative, given the high disease burden, triple front morbidity, and also the opportunity of allied health professionals is a global opportunity. It is not only important that India, being with its blessed demographic dividend, should not only think about planning allied health professionals. We require them first and foremost for India, but the opportunities really are significant as we look at other export and other sort of global countries. With that, we have done a little bit of dipstick into these 10 allied health competencies that have been outlined. I'll start with optometrist. Our estimate is we have currently qualified optometrists of about 15,000 in the country, 15,000 to 20,000. So of that constitutes about 65,000 per, one optometrics per 65,000 population. At secondary, tertiary, varies by region. Real requirement at an industry level is at least 8x to 10x more. That means the gap is about 100,000 optometrics. Physiotherapies, again, we have 200,000 registered, at least 500,000 gap. We see about 1 million physiotherapists required. And especially if you look at the skewed distributions driven by inequity and geographical gaps, it's that number actually could even go up. Medically laboratory science professionals, currently we have 30,000 to 40,000. We need at least 300,000, about 250,000 gap. And that's 40 to 50% gap in qualified lab technicians. Gap will increase as testing and the non-communicable diseases and the health-seeking behavior, the health system usage increases. Dialysis therapy professionals, about 1%, as we all know, of the general population has renal failures. The core problem today is the sheer volume of patients every year. Approximately 220,000 new patients are diagnosed with end-stage renal diseases, creating an additional demand of about 34 million dialysis sessions annually. We have about 25,000 dialysis therapy professionals. We need at least 75,000 with a gap of 50,000, these are all numbers as on. Medical radiology, imaging technologies, we have 15,000. The gap is about 30,000 to 40,000. The current ratio of radiologists to the population is approximately 1 per 100,000, far below international standards, creates an immediate gap of 30,000 to 40,000 professionals. These are medical radiology and imaging technologies. Just talking about radiologists separately, India has both a machine shortfall in radiology, approximately 823 radiology machines against a minimum requirement of about 1,500 to 2,500 machines to meet cancer burden. Then the utilization gap, in terms of utilization gaps, about 1/3 or 2/3 utilization upside we see in the coming 5 years, creating a radiologist shortfall. From today's 15,000, 20,000, we need to double the gap. Anesthesiologists, OT technicians, it's a significant gap today. Today we have about 1.3 per 100,000 population. The numbers at which we need would be about 2.5 to 3 per 100,000, creating a gap of 850,000. We need about 3 OT technicians per operating table in that sort of a number as we go. EMT paramedic, many are unaccredited today, unqualified. While the numbers seem large, 2 million, it's really, if you look at it, 2012 PHFI study, a general shortfall numbers, an estimated 80% of existing ambulances are not equipped by trained qualified paramedics. Significant gap exists even across the regions. We anticipated 2 to 3 million gaps, the total requirement for EMT and paramedics serving both the remote communities, the chain from community to definitive cares of care, which is hospital and hospitals. That's a gap of about 2 to 3 million EMT qualified paramedics. Significant shortages in applied psychology, behavioral health, and occupational therapy. We estimate in these two cadres altogether about 100,000 to 150,000 gaps. And it is driven by, there are clear global standards. For example, clinical psychologists, 3 per 100,000 people population. And also in the occupational therapy professionals, there's no nationwide census that is required, but at least it's estimated generally out of a number of industry survey that we have a 50% shortfall. So net, if I were to take all of these things together, in just 3 categories, EMT paramedics, OT technicians, medical lab sciences professionals, there is an immediate gap of 2.5 to 3.5 million, qualified professionals. Other categories contribute another 0.5 to a million. This is just in the short to medium term. The longer term volumes, as you grow above 5 years, these numbers, as you create more and more seats, those seats really have to cater to the existing gap as well as the demand, even out of the per capita demand. Let's put it that way. A significant growth is ahead in terms of our ability to serve the existing legacy disease burden and the new burden that is coming ahead. Therefore, our goal should be to mobilize large volumes of AHPs across India, really position this as a respectable, professional, and a rewarding career, and really get large volumes upfront early into this formal professional sector. I compliment the National Commission for Allied and Healthcare Professional, the regulatory body, Ministry of Health and Family Welfare. The act is very timely, and the interventions that we create today holds tremendous potentials to create structural unlocks to break the modern allied health professional cadres that are distributed across nations, allows us to deliver care in the last mile to the patients, improve health outcomes, and takes the nation towards Viksit Bharat. With that, ma'am, Dr. Kotwal, I hand the mic back to you. Thank you.
Thank you so much, Acharya-ji. I think you have actually shown us that how much is the requirement which will be there for the allied healthcare professionals in time to come. And now I would like to, having got the inputs from Dr. Shukla and you, I would like to know, because ma'am also referred to in her intervention that, there is a possibility of using existing infrastructure. Can we, use the, it's not always, I would say, sustainable to always create something new. So is it possible for us to upgrade what we have now, and can we use leverage the existing assets that we may have? So with these thoughts in mind, I would like to ask Dr. Sanjeev Singh that how can existing allied and healthcare colleges, institutions be strengthened to accommodate the growing demand, which you have heard Shri Bhattacharya ji mentioning in his intervention, without compromising on the quality? Think we can leverage the existing assets that we have, whether most importantly in private sector. So over to you, Dr. Sanjeev Singh.
Yeah, thank you so much, madam, and thank you for this invitation. And we heard you and the Secretary Health, madam, and it was very nice to know.
We can't see your video.
Oh, my video is on, madam.
Okay. I'm not able to see. Are other panelists also able to see?
No. I think
okay. Yeah, now it's on. Thank you, Dr. Sanjeev Singh. Now we can see you.
Thank you, madam, for this invitation, and thank you for bringing this subject, which is very, very relevant. We at Amrita had been running allied health sciences courses for almost 26 years, and we recognize the importance. We were part of the task force along with the Government of India and Public Health Foundation many years back, and very succinctly put by Dr. Bhattacharya that it is the requirement, the gap exists. When we calculate running a hospital, a good tertiary care hospital, for one bed there are 5 professionals which are required, and out of that there are 2 which is allied health sciences when we calculate the manpower. So we would be requiring close to 60 to 80 allied health sciences per 100 beds. So in that manner we might have to double the number, and that can be done because there are 818 medical colleges now, and there are, as you mentioned, there are close to 20,000 plus good private hospitals which are existing. So we can convert the existing hospitals into teaching and skill training hubs. There are 637 district hospitals. So those who are interested, who have the infrastructure, those medical colleges and those quaternary and secondary private hospitals can be designated as allied health science training centers. We can integrate the allied health science program in the medical college, and that would be very easily done because the pre-paraclinical subjects are already there in place. So we need not get people for anatomy, physiology, biochem, labs, pathology, and other things. So we could use the tertiary care hospitals and the super specialty because they already have very advanced operation theaters, critical care units, and physician assistants. And this would possibly utilize and reduce the cost and utilize the existing patient volume. Other than those medical colleges and quaternary and district hospitals, it would be also important to upgrade the existing allied health institutions. There are many, many institutions. It would be more than 3 lakh institutions, some in organized way, some in very unorganized way. They run allied health science programs. So if we can upgrade them, either attaching them to the district hospital, attaching them to the medical colleges nearby or to the private institutions, and providing some kind of a simulation laboratories, skill labs for some emergency medicine, critical care, which the courses which you have already announced, and do some digital training with standardized classrooms and assessment pattern. We possibly could also upgrade the existing institutions who have been running this program. As you rightly mentioned, one nation, one curriculum, this is extremely urgent and important. So standardizing this curriculum, because there are these institutions, more than lakhs, which are running allied health program for many years. And we are very fortunate now that the National Commission has been established. So this particular curriculum should get standardized and accredited, and the competency-based curriculum with uniform licensing and maintaining the registers should be sort of adhered to. At this juncture, I would also request if MBBS, MD, DM, PhDs can also be included as part of the teachers. That would be nice. Right now, I think it is mostly the bachelors in the remaining program, in the respective programs, or masters and PhDs in the respective programs are considered as senior lecturers and assistant professors. It would be also important that the skill development and the university teaching hospitals get aligned, and these courses can have that alignment with the national skill qualification framework. So the short-term and certificate programs could get converted, and the technician programs which are already running, the bridge programs could be established. The private public partnership, because if 67% of the healthcare is delivered by private, it would be very important that they participate, and we are very fortunate that Dr. Girdhar Gyani is here as part of the panel. So these mandatory teaching affiliations could be established with them, and the industry support for these lab and medical equipments, because they would have that would be extremely critical. While we do this, madam, it would be good to create center of excellences, because people should know that this is doable. And this, when you create such kind of institutions, it adds value. So regional hub and spoke model could be established, because they need to come, visit, and see that a good training and good skill development is happening for critical care, radiology, medical labs, emergency, and things like that. Till we get to that level, it would be also easy, or we should explore digital and simulation training, because there are lots of extended reality, virtual reality, mixed reality labs which have been established. It has been done for medical undergraduate and postgraduate. It is also done for nursing. And till the upgradation of these institutions happens, who would provide the training, we could have a virtual lab platforms. There could be also, since AI is the buzzword, and we could possibly use this fantastic technology. So AI based, some of these training programs could also be established. If there could be national simulation center and an assessment or a telemonitoring done, then we could get ball rolling, and we could be on the runway, and we could easily take off in a very short time. Lastly, I think it is important to strengthen the faculty while we are strengthening infrastructure, because these faculty would be extremely critical to be provided the right kind of training to these allied health science people. So the faculty exchange between hospital and university would be important. There are lots of retired professors who, after 70, they superannuate from the medical colleges, or otherwise in some of these private hospitals who have a retirement plan of 60, they superannuate. So they could be sort of brought in the mainstream, and some incentivization program could be done for the clinicians who would get into academics. Here I would still request, if MBBS, MD, DM could be considered as faculty, and a parallel clinical designations can be given to them, because the medical colleges can easily then run all the courses which you have already announced. So this, with the integration of these workforce planning and with the existing healthcare system, I'm sure under your guidance, a lot of work can be done. And we would definitely like to participate in whichever manner you can. We have this experience for the last 26 years. We are doing that at Kochi and Faridabad, and we would like to contribute for this particular stream. Thank you very much for giving this opportunity.
Thank you, Dr. Sanjeev Singh. It's very nice to hear, because your interventions are, I would say, coming out from the experience that you have of running a hospital and a medical college, and what you can foresee are the low hanging fruits which we can use to roll out this, because we don't have much time. We have to start rolling it out from this year onwards. So what are the immediate steps that we can take to start rolling out the whole initiative of adding these? Thank you very much for your intervention on this point. Now, I would like to change the track a little bit and go towards the government side. And I would like to request Dr. Samant that you have heard Shri Bhattacharya ji on the demand side that he has mentioned, and you have heard Dr. Sanjeev Singh is coming from a private perspective. Now, since you are running a government institute, I would like to hear from you that what can be the strategy that we can adopt for similar rapid expansion in the government institutions that we have, and for this strategy, what are the challenges that you foresee which can come in the way? So, Dr. Samant, we would like to hear you from your experience of running a college also, which I think is doing not only allied healthcare professions, but pharmacy and nursing as well. Yeah.
Yes.
Thank you.
Thank you so much, madam. I hope I am audible. And thank you for inviting me to be part of this session and share my some of the views on this. I'll try to restrict myself to your very two important questions: the strategy for rapid expansion and what kind of the challenges that we can face in the whole process. I think after listening to Dr. Bhattacharya and listening to Dr. Sanjeev Singh, now we are realizing that what is the demand, what is the gap, and what are the current number of institutes, what is the intake capacity now. And if you could see, I think it is government to private, if we compare, it is 8 times private is more in number, and government is hardly with the 500 institute and 48,000 intake capacity. I think in country like us, this is very, very small number of 48,000 intake in the whole nation. So, so I feel what is important is to set the goal for the numbers to be increased in the uh, government institution. And I feel that number has to be reasonably high, because these are AHP courses. The kind of remuneration packages and then salary that could be offered in the private sector may not be very, very high to attract these students from very high uh, economical background, as well as the very high merit, because naturally the medical, nursing, pharmacy, and dental and other courses would be the first priority, and HP courses would be a relatively lesser priority by the students. So keeping this in mind, the low fee structure is very important, and therefore it prompts the government institutes and hospitals to uh, keep the higher intake capacity rather than what we expect much from the private organizations. When I'm saying this, government institutions, naturally it covers central institutes, state government institute, and we should never forget the district civil hospitals, where the MTMS programs are not run, but they run the DNP programs. So they do have a similar kind of the medical programs to run as an experience. And therefore, I feel what is important is to first see and assess the intake capacity in the central and state government institutes vis-a-vis with the current infrastructure, facilities, learning resources, and faculty as per the NCHP norms. How many seats that we can increase? That can be first small, quick assessment can be done. Second, I feel with the existing institute, with the little additional infrastructure, physical facilities, learning resources, little additional more funding requirement, and the faculty, how many seats we can increase without much increasing the physical infrastructure, by introducing only equipment, few laboratories, and approval of the more number of the faculty, how much we can do it. I think these two exercises will help us to help in the setting the goal for the government institutes. When it comes to the setting of the new government institutes, I think there simultaneously we'll have to also undertake the feasibility studies by the government, that how many institutes in say next 5 years of time we can introduce. I'll just quote one example of own Ripans, wherein ministry had set up, had a plan to establish a satellite campus of the Ripans in Alo, Arunachal Pradesh. However, since our current upgradation program for the Ripans is going up, and I am very happy to share with you that since Ripans is the only institute under the Ministry of Health and Family Welfare, Government of India, which is going to have operationalized its own 100-bedded hospital. Probably all the hospitals are, all medical institutes are attached to their own hospital, but Ripans is the only institute where we will have our own hospital to be made functional in maybe a couple of months soon. So what point I'm trying to tell you, when I said Ripans campus satellites to be launched in the Arunachal Pradesh, similar kind of the exercises can be also taken up by the government, wherein the own institutes of the government do have the expertise, knowledge, and can expand in various parts of the country. Now, once we set up, get all these inputs, what I feel is we need to prepare our action plan, roadmap, strategy, whatever you call, uh, and based on this, I think we can go ahead what we can rapidly achieve the increase in the intake capacity of the identified areas. Second point, I feel since the Commission has mandated these disciplines to be regulated from next academic year, what is important is the Herculean task to the Commission. And we need to first see what is the preparedness level of this Commission in terms of rolling out the curriculum, in terms of approval, conducting the inspections, availability of the experts, assessment of the infrastructure, physical facilities, faculty for approval, extension of approvals in time, very time-bound manner. Since the commission is first time established, I don't know whether they have already acquired the IT infrastructure for online approval process of these courses. Whether whether the commission is ready with the curriculum for the identified courses. If not, then that needs to be done on priority. We need to also see that to speedy approval of these programs, we need to have the empanelment of lot of experts, and not only the subject experts, but experts from finance, legal, civil engineers, even the architects, because they need to actually check the the financial position of the institutes, especially for the private organizations. When it comes to the commission, for commission, government or private, it is one and the same. But unless a good empanelment of the experts is done, commission may not be in position to achieve the timelines and complete the approval process in time. So the preparation of the annual approval process, plans, schedules, and achieving those, the approval process to be given would be very, very important stage for the, the commissions or like AICT and then others statutory bodies. They have been working for so many years, so they have learned over a process, over a period of time, some of the challenges, difficulties, and their approval process have been very time tested. For this commission, this is going to be first time, so I think ministry will have to also have a lot of hand holding whenever it is required, strengthen their IT infrastructure on high priority. If this is done and then goals are set well, probably the commission would be able to approve the processes. Give the approvals to all these institutions well in time. We will have to also keep in mind, because these courses are going to be affiliated to the either central universities, state universities, or even the private universities, deemed universities. So they also are going to take some time. All these central state government universities, they do have their own acts, and they have to follow certain procedure before granting the affiliation. So that time required, we'll have to keep it in the mind. So once this is done, I feel the task force could be formed, the work allocation could be well done, these action plans along with the monitoring and review mechanisms well in place, probably we will be able to achieve the target that we are setting. Now, coming to the next second point that you had asked, what could be the challenges, what I personally foresee in this expansion. I think the very, very important is the approval process for being undertaken or to be undertaken by the commission. So if they do have adequate infrastructure, facilities, readiness to do this in time, I think that would be a great thing in achieving the setting, achieving the goals for the increase in the intake capacity. Right. Second, when it looks come to the faculty norms, I think if there are no much representations, then it is okay. But if there are certain representations in rationalizing the faculty, like in institutions where allied health profession courses are run, there are faculty which is very, very common for subjects like anatomy, physiology. I think Dr. Sanjeev Singh also said this. And there are certain common infrastructure facilities like libraries, certain laboratories also, where uh, I think those can be commonly shared. If the regulations allows, it is well and fine. If regulation doesn't allow, I think we need to relook into it. And if wherever it is required, some rationalization, that rationalization could be done on priority. Otherwise, if that is not done, and then approval process is rolled out, and once in the online approval process, all these parameters are set, the online approval process will automatically reject a lot of applications, and then there would be greater issues coming up. So we need to visualize all these issues and then see that how we can do it. uh, I said about faculty, like common infrastructure in government institution, what probably would require more would be additional faculty, and they recruit fast track appointment, first the approval, post creation, and the filling of those post. There would not be much problem in getting the faculty, at least for the government institutions, but uh, the fast track approval, administrative and financial approvals are very much needed. uh, for some of the courses to be introduced in institutes, in government institutes which are currently not run, where if we require certain equipment, some laboratories to be strengthened, the procurement process would also take some time. So I think all these factors, if we keep it in mind, we will be able to roll out the rapidly expansion of the intake capacity. Already I have mentioned the some time constraint for affiliation that should also be taken care. The we will have to always keep in mind that since most of these AHPs are going to be uh, employed in the private sector, in the hospital setups, their compensation packages, salaries uh, probably may not be very high. So if wherever possible, if government could do something to look into their compensation packages and this thing, probably we would be able to attract more manpower to the AHP. And and government should take more figures to into account for increasing the intake capacity. That's what I feel. These are some of the points. And only last point that I would like to mention, like courses like in dialysis therapy, anesthesia and OT technology, emergency medical technology, burn care technology. These are the courses which can directly be introduced in the district civil hospitals, where already they do have infrastructure, facilities, faculty. And it was rightly mentioned by Dr. Sanjeev Singh that we will have to have the medical faculty as one of the faculty members for the AHP. If you look at the RRs of the RIPANs, we do have both the qualifications, medical as well as non-medical. And of course, probably the chairperson of the commission has some certain other views to say, and then she can definitely reflect on it. But this is what I feel we all learn through multidisciplinary and transdisciplinary approaches and capacity building. Our commission's focus should be more on training, the internship, posting, because these are all skill-based courses. So if there is little compromise on some infrastructure in the initial period, we should take that into consideration, but there should not be any compromise on the clinical posting, training, internship in the hospital setup. If this we could do it, I think probably we will be able to rapidly expand the intake capacity in the HP areas. Thank you so much.
Thank you very much, Dr. Samant, for sharing your views with reference to the what you think can be the strategies for expanding the existing capacity in government institutes. But let me just here tell you on behalf of the commission that commission is already working on an IT platform where all the registrations, once they are in place, will be through an IT system, and so that the approval process is faster. And I think we have noted down some of the points which have been raised by you during your intervention. Now, I would like to invite Dr. Anurag Shahi to say a few words. I think we have heard all the speakers talking about three important pillars for allied healthcare education, which is related to infrastructure, faculty, and clinical material. Just like medical education are the three pillars on which the allied healthcare education is standing, will stand and will grow. So, how do you think, from what I could hear from Dr. Samant, that the institutions may be ready in certain aspects of, for example, he is coming from a government institute, so he's comfortable with reference to the infrastructure part, but he also made a reference to the faculty part where he said maybe we need to have faculty from other than allied, we need to have faculty from, let's say, medical fraternity, as was said by Dr. Sanjeev Singh also. So, since you provide a platform from the demand side as well as the supply side, so I would just like to understand from you. Try not to repeat what has already been said, but from your experience, what do you think are the institutions? How are they placed to address these components? And what do you think are the steps that we need to take so that we can achieve the objects that have been laid for us in the budget announcement this year? Over to you, Dr. Zahid.
The esteemed panelists, and thank you to the Ministry of Health and Family Welfare for convening this and inviting stakeholders to contribute to this important discussion. The participation of private institutions reflects the government's commitment to Jan Bhagidari in strengthening the system. My name is Dr. Anurag Shahi, and I had academics at Virohan. So this is a landmark movement for the allied and healthcare profession or AHP sector, especially following the Honorable Finance Minister's budget announcement to add 1 lakh AHPs over the next 5 years. Before sharing my perspective, I will just take a moment to briefly outline the structural workforce challenge facing the country. Today, India faces a significant gap in the healthcare workforce capacity. Current estimates suggest that the healthcare sector requires roughly 10.9 million professionals, while the current supply, as mentioned by Dr. Bhattacharya, is about 2.75 million. This leaves a structural gap of more than 8 million healthcare workers. And most importantly, nearly 60% of this demand lies within the AHP domain. This gap contributes to diagnostic delays, service variability, and workforce strain across the health system. Therefore, the policy priority is to solve for a dual challenge: rapidly scaling AHP education while maintaining quality. And as ma'am mentioned, the growth of AHP education rests on three pillars: infrastructure, clinical exposure, and faculty. The encouraging point, as we've seen, is that across many universities today, the foundations of these pillars already exist. Universities already have classrooms, laboratories, and faculty. So, the opportunity before us is not only to build new capacity, but also to unlock and scale the existing institutional capacity through calibrated implementation. In this regard, the NCHP regulatory framework is an important step forward. This is widely seen as necessary and timely across the sector, especially with the introduction of standardized competency-based curricula starting from academic year 26-27. Based on our engagement with universities, there is broad agreement on the direction of reform. But there's also a need for greater operational clarity on the implementation pathway. In particular, Section 40 of the NCHP Act, which mandates prior permission, has created significant uncertainty. As also mentioned by Dr. Sanjay, this uncertainty is impacting the current structure. Universities are currently uncertain as to whether they can continue admissions under the new NCHP aligned programs without explicit approval from the state councils for AHP. Since many state councils are still being operationalized, several universities are currently adopting a conservative interpretation of the guidelines. As a result, institutions that already have necessary infrastructure, faculty, and clinical partnerships are hesitant to open admissions for the upcoming academic year. This is particularly important because this exactly is the time when class 12 students make their higher education decisions. Without regulatory clarity, there is a significant risk that existing national training capacity may remain underutilized in the academic year 26-27. One possible implementation step could be a clarification or a continuity circular allowing UGC recognized universities to continue or commence programs during a transition period, while the state level regulatory architecture is fully operationalized. This would help ensure continuity of admissions and preserve existing national training capacity. Briefly touch upon the three pillars of expansion. First pillar is infrastructure. Adding on to what Dr. Sanjeev and Dr. Sanjay mentioned, many institutions with strong track record of producing high quality AHPs have the capacity to scale. But certain infrastructure norms may be aspirational in the first year of implementation. Some NCHP notified curricula prescribe infrastructure standards that may be difficult to operationalize in the short term, especially in Tier 2 and Tier 3 regions. In such cases, phased implementation with minimum standard requirements to start with and shared infrastructure models like district level common facility centers or shared partner setups could help institutions align with the new standards without slowing expansion. Second pillar is clinical exposure. Some NCHP notified curricula require rotations in specialized departments, such as robotic surgery, cardiothoracic surgery, and neurosurgery. These facilities are concentrated in a limited number of tertiary hospitals, which can make compliance difficult for institutions in non-metro regions. Another important aspect relates to the interpretation of the attached hospital requirement, which may limit the utilization of standalone healthcare establishments such as Dr. Lal Path Labs or others, even though these facilities handle a significant share of diagnostic services. Flexible rotations, network-based clinical training, and recognition of standalone healthcare institutions as training partners could significantly expand training opportunities. The high patient load in government hospitals is a valuable training asset. Allowing students across institutions access to these facilities via structured MOUs could significantly strengthen practical training capacity. Let me now turn to the third pillar, which at this point is perhaps the most binding constraint: faculty. Across our engagement with universities, three aspects of the faculty challenge become clear. First, faculty-student ratio norms. Some NCHP notified curricula prescribe quality-focused aspirational faculty-student ratios. For example, MRIT mentions 1 is to 5 and MLS mentions 1 is to 15. In emerging AHP domains, where the faculty pipeline is still developing, meeting these ratios across programs can become significantly difficult. Second, prescribed staffing structures. Some curricula also prescribe fixed faculty structures. Programs with intakes of around 30 students may require up to a total of 15 professors, associate professors, assistant professors, and tutors. This stacking of requirements can make compliance difficult, even for institutions that otherwise have the capability to deliver strong programs. Third, senior faculty eligibility thresholds. Some curricula also mention additional eligibility criteria for senior faculty, including doctoral qualifications, experience thresholds, and up to 10 indexed publications. However, many AHP disciplines are relatively young academic domains. The AOTT and dialysis therapy technology curricula acknowledge this constraint. The pipeline of senior academic faculty is still developing, creating a mismatch between requirements and the available faculty pool. When ratios, cadre structures, and publication thresholds operate simultaneously, institutions may find it difficult to comply with all requirements at once. In some cases, this may even discourage universities from launching AHP programs, despite having otherwise adequate teaching capacity and clinical partnerships. Given the national priority of expanding the AHP workforce, this becomes crucial to address. Few implementation pathways could help address this constraint while maintaining high academic standards. First, ratio-led staffing. Where student-faculty ratios are prescribed, they could serve as the primary determinant of staffing compliance. Cadre composition could be treated as preferred during a transition period, allowing institutions to progressively build the full faculty structure. Second, flexible eligibility through equivalence pathways. Similarly, publication thresholds and other eligibility requirements for senior faculty could be treated as preferred qualifications during the transition phase with approved equivalence routes. This would allow institutions to appoint experienced practitioners who may not yet meet all research publication criteria but are capable of delivering high quality teaching. Third, professor of practice pathway. Another promising approach is the professor of practice model, aligned with the national education policy. This would allow experienced practitioners to contribute to teaching and clinical supervision. Such practitioner faculty pathways can play an important role in AHP education, where clinical expertise is central to training. Fourth, national faculty development initiatives. There's also a need for system level investment in faculty development. Structured training of trainer programs, potentially anchored through institutions such as NIHFW, could help develop a sustainable national faculty pipeline. This would support both capacity expansion and standardization of teaching across institutions. Finally, rapid scaling of AHP education will require alignment with the existing higher education ecosystem. The entire academic ecosystem in universities, including all undergraduate and postgraduate AHP programs, currently operates under the National Credit Framework or NCRF. The NCRF is a unified meta framework inclusive of the NSQF, the National Skill Qualification Framework, for seamlessly integrating higher education qualification across central and state institutions. Hence, explicit alignment of the competency-based AHP curricula with NCRF will support faster adoption across universities, while enabling modular learning pathways and stackable credentials. This will also further the vision of the competency-based curricula, as NCRF is an existing framework that aims to do the same for all higher education qualifications. For clarification, allowing universities to continue submitting regulatory documentation within the NCRF structure could therefore help smooth implementation. From our experience, working with more than 20 higher education institutions and serving on over 10 board of studies, there is strong respect within the academic ecosystem for the work undertaken by NCHP in standardizing AHP education, especially with the one nation, one curriculum philosophy. This reform will significantly improve the quality, consistency, and credibility of AHP education in India. Achieving the vision of Viksit Bharat 2047 will require significant strengthening of India's AHP workforce. AHPs form the backbone of modern healthcare systems and are central to moving from a doctor-centric model to a truly patient-centric healthcare ecosystem. Strengthening this will therefore be critical, not only for expanding healthcare capacity, but also for building a resilient and high-quality health system for our country. Thank you very much.
Thank you, Dr. Shahi, for sharing your experience with reference to the work that you do with the institutions across the country. Now, at this point of time, having heard, stakeholders who come from private, government, regulator in NCHP, I'd like to bring in Dr. Avijat Sheth, Chairman, NMC. NMC has a longer history of regulating the medical education in the country. Prior to it was MCI, and now we have NMC. Sir, I would like to ask you that, drawing upon your extensive regulatory experience that you have as chairperson, NMC, and also currently as president NBMS, and as a cross-learning endeavor, what strategic framework would you recommend to scale allied healthcare programs in this country, and also that we add seats without compromising on the educational standards? Do you think leveraging digital technology can help us in this way? Because it would be really wonderful to hear from you that there are some challenges that we face in medical education. So I would like to hear your thoughts on what do you think we can do to achieve the goal that has been set to us, and what would be your advice to us in this? Sir, over to you.
Namaste and very good afternoon to you and all the panelists and the viewers. On behalf of the National Medical Commission, I extend my gratitude to you, ma'am. I will just briefly give my share my professional experience on certain points. First of all, we have to understand that medical professionals cannot work without allied healthcare professionals, and allied healthcare professionals cannot work without medical healthcare professionals. There is a need of strategic integration for the purpose. And what purpose is? Purpose is to give the better patient care. Purpose is to ensure better patient safety. Purpose is to ensure the better professionalism, and there's a win-win situation to both allied health care professionals as well as the medical health care professionals. As far as the regulatory framework, ma'am, which you say, I think the core principle remains the same, whether it's a professional, medical professional or allied healthcare professionals. The basic three principles is we understand that objective evaluation tools, competency-based assessments, and strong regulatory oversight. I think these are the most important tools for regulatory framework. That includes audits and everything, which is just a inbuilt part of the regulatory framework. And this framework doesn't change for allied healthcare professionals or the medical healthcare professionals. The most important part which we now understand, that medical professional is highly dependent on imaging and lab diagnostic procedures for their effective healthcare delivery. And hence, I feel that it's a high time that some strategic framework must be adapted to support both the expansion of the allied and healthcare programs while maintaining the high educational standards on either side. One of the concepts which I'm trying to introduce, I know since many years, even in the National Board of Examinations also, is a interprofessional education. This concept is a well-recognized concept, but it's in the transition at the moment. We need to develop this concept, and this concept will certainly bring both allied healthcare professionals and the medical healthcare professionals together to the what we call it a team approach for the medical education, and both the specialities, the allied specialities and the medical specialities, will learn from each other by sharing their knowledge, sharing their experience, and sharing their expertise. And certainly, this is what we need to build up. If we start today, it will take some time to build up this model, but this model is well accepted, well recognized, and we should try to bring it in the practice for the purpose of effective teamwork. I think we all know that now isolated doctors or isolated allied healthcare workers are no more going to exist. It's a teamwork wherever we work, whether we work in the big hospitals, corporate hospitals, or we work in the rural areas, or we work on in the home care. We need certainly the integration of all these healthcare workers approach together for the best healthcare deliveries. So that is one. The another is another part which everyone has discussed about the how you can pull the medical professionals to align with the allied healthcare professionals. Let us take an example. Let us take a view that what they have their council now, and council is working very well to establish the standards. Now, one area which possibly the allied healthcare professionals have an advantage about identifying their human resources is the aptitude test. Unfortunately, for the too much of issue of subjective biases in the medical profession, we couldn't bring this aptitude test or the selection along with the merit, also with the help of the interviews, never happened in the medical profession. But I feel that this is something which is doable in allied healthcare while staying within the regulatory framework. If you built up that criteria, and certainly this will be greatly helpful because these healthcare professionals are linked to the skills, technical skills, the machines. They are linked to the what you call it, the complexities of today's medicine. So that is something which I would recommend from my side. I express my views on this side. The other important area is about the education, how we can bring the doctors to align with the allied healthcare. Yes, fine. Let us have a teamwork approach and interprofessional education. The one of the objective tool, the biggest objective tool is digital e-learning platform. I think there is no bar. There is no bar for digital e-learning platform for any allied healthcare person to join for the education, to get the knowledge, to get the exposure, same as what medical professionals are doing, and vice versa. I remembered that in my earlier time, I learned a lot of skills from allied healthcare professionals. They were not doctors. Doctors I learned for the patients, but the skills, required technical skills, I learned from the allied healthcare professionals. So, digital e-learning platform can play a huge and cost-effective solution for the strategic framework of the allied healthcare professionals. Now, the another important point that when and where we should start, I think this should be start during the undergraduate program, because in undergraduate program, what the medical professionals are doing is a preclinical exposure, and it's not a direct clinical exposure. And if this particular what interprofessional education or integration of allied healthcare professionals and the medical professionals. This should be done at an earlier stage rather than we should bring it at a later post-graduation stage. That is what the another important point which I learned from my experience with different institutions across the board. And what is another important is we have to encourage the holistic healthcare approach and integrate multidisciplinary perspective and patient-centered care in healthcare education and training. We have all sorts of experts are here. We have Professor Girdhar Gyani is there, who has been instrumental in establishing the accreditation of the hospitals across the country. And we have seen that when such objective exercise has been created, this is exactly what will give insight to build up the strategic framework. That if you build up the objective exercise across the board, then this will have a very positive outcome. Because I know my own institute before the pre-NABH era, and I know my institution after the post-NABH era. And there was a huge paradigm shift has happened that not only the professional used to work in isolation, but that bring the professional to work as a team, plus towards the patient safety, plus towards the patient-centered care. So all objectives will be achieved at an organizational level. We need what we call it to develop the organizational culture, and for that, these tools will be very important. And what last is the resources, how we can build up the resources. We must motivate already well-working institutions as far as which has got a patient volumes and which is already working and they are not utilized for the purpose of education. These again applies to the both allied healthcare professionals and medical healthcare professionals. We must work it out to both of them to ensure that these institutions should be motivated to start the foundation, well, to lay down the foundation as far as the educational courses are concerned. And certainly, we need to upgrade ourselves with the technological advancement, with the everything like lab sciences. We have to adapt innovations. We have to adapt the clinical research. We have to adapt all the new complex healthcare solutions. But final summary, which I feel that we must link the program continuation and all the amendments to link it to the measurable outcomes. And we must make sure that we built up this teamwork approach right from the beginning to the level of development of the clinical insight together. And I ensure that the National Medical Commission will be very happy to be a part of this strategic framework. And with that, my best wishes to all of you. Thank you so much.
Thank you, sir. It was indeed heartening to listen to you talk about the team-based approach that we should have for delivery of healthcare to the patients. And also, I was really happy to hear about the concept you talked about, interprofessional integration, cross-learning, and the point where you talked about maybe this integration can start happening at the youth level when the students have these common subjects, preclinical subjects that they study. So it would, in my opinion, lay the seeds for the team-based approach to go on once they have done their courses also, because the foundation would have been laid at that point of time. So it was very, and it was also wonderful to hear that you together to consolidate the robust framework that Madam Yagna Shukla is trying to bring under the NCHP. Thank you, sir. Now, another important partner for us in rolling out the numbers would be the states. We are joined by a very dynamic officer from Odisha, Ashwati. She has been doing excellent work, I would say, in the area of health in the state. She is very proactive and visionary in what she thinks needs to be done. That's why we invited Ashwati for this discussion. And from you, Ashwati, I would like to hear that there are a number of government institutions in Odisha which are running allied healthcare courses. So could you just tell us that what is the how are they spread out? Public versus private, what are the kind of courses they have? And as we go ahead strengthening this, what are the kind of bodies that you expect can help us in the out? The floor is open for you to for your intervention, Aswati.
For this opportunity, and then indeed pleasure and the privilege to be part of this esteemed panel. Now we have done a gap analysis for Odisha in terms of identifying which are the causes that will help us in a futuristic perspective. And we realize that we have 64 institutions that are providing allied health courses, and cumulatively, we have approximately 8,200 seats that are part of these 64 institutions. However, when we dig a little bit deeper into the spread and patterns that are there in the spread of these courses, we understand that there are two main patterns that are emerging. One, overwhelmingly, the institutions are in the private sector. So out of the 64 institutions, 10 we have in government and 54 we have in the private sector. And the second pattern that emerges is that when you look at the kind of courses that are offered by the 64 institutions, we find that there has been more flexibility in adaptation in private sector than in government. So again, in Odisha, overwhelmingly, the courses offered are in the traditional spectrum. However, there are some private institutions that have come forward and introduced maybe a little more futuristic course expansion when compared to government. So with this context, we did an internal consultation in trying to understand what should be a strategy for expansion, especially in the government sector for Odisha in the future. And when we sat together as a group, we also realized that we need to understand certain guiding principles while undertaking an exercise of this sort, because we need to plan ahead. If we have to plan ahead, then we need to understand what is it that we are planning for. So for Odisha, we realized that there are perhaps 5 or 6 major trends that are likely to happen in the future, for which we need to prepare ourselves, whether it is in the medicine field, whether it is in Ayush, whether it is in paramedical or in allied sector. And which are these 5 or 6 trends? One is the fact that Odisha is the cusp of a demographic shift. And we realized that by 2036, when the state would be celebrating its 100 years of existence, almost 1/4 of our population would be 60 plus. So there is a huge shift in the policy that is required, and also in terms of preparedness that is required from our side in terms of policies towards the geriatric care and policy. So that is one major trend that we foresee is likely to happen. Second is that we will have to be prepared for the extreme events of climate change. Now, Odisha has been facing a lot of, as you must have all heard of, a lot of extreme climatic events like cyclones and floods, more so in the last 1 decade. So I think this is something that we will have to be prepared. The health system will have to be prepared as a team. Number 3 would be urbanization. Again, by 2036, we expect that almost 20% of our or more percentage of our population would be staying in urban areas, again, there are multiple issues which the current rural-centric health system will have to be reoriented. So this is a major trend that we will have to take care. Number 4 would be the triple burden of diseases. Odisha has a huge burden of communicable diseases, whether it is malaria in our tribal pockets. There are 8 districts that are even right now high burden in terms of malaria. We do have pockets for leprosy. We do have pockets of even LF and even TB. So therefore, there is a huge spectrum of communicable diseases that we are dealing with. But of late, there is a huge burden of non-communicable diseases that is coming. In fact, one of the former speakers had also mentioned how dialysis technician is going to be a course that one should start immediately. In fact, we are dealing with increasing CKD in Odisha. So, but dealing with these both communicable and non-communicable and trauma and injuries is going to be a major challenge that Odisha is likely to face. And last but not the least is the changing societal structure within the state. So how does that impact? In fact, we are moving towards even from a joint family structure to a nuclear family, and also a lot of with the changing urbanization and the changing societal structure, we feel that there will be a lot of mental health related challenges that the state will have to deal with. And so with this kind of a futuristic understanding, when we look at what is it that we need to do now that will help us in being prepared for the future, in fact, there are multiple points that emerged. One is that how do we keep up ourselves with the technological workforce requirements and advancements? How do we understand what is the need for a public health system? Not just from a provider perspective, because when we are looking at provision of allied healthcare courses and services, the state feels that perhaps we should not just looking at skilling for Odisha, perhaps we should look at skilling for the rest of the country and even rest of the world. So how do we understand what are the public health emerging trends that is happening across the global healthcare market as well? Now, given this, when you look at what is the services that we get at the moment in trying to improve the health sector reforms, one of the foremost support that we have been receiving is the central assistance. So there are multiple center schemes that we have been getting. In fact, that has been instrumental in expanding the medical courses that the state has to center assistance. However, such assistance has been in the form of a financial assistance primarily, wherein the center would be giving 60% financial assistance with a matching 40% share from the government. Now, there are a number of suggestions that we had in this regard now. One is that Odisha is a state that has been consistently investing in health sector. In fact, we in the current budget that is placed before the assembly in Odisha, 7.5% of the entire state's budget is given to the health sector, which is one of the highest anywhere in the country. Now, given that kind of a financial commitment from the state government, one challenge that we face with the 60-40 arrangement is that there is always a cap on the courses that the state can absorb. So if the state is able to provide a matching share, so perhaps one can think of flexible approach in the cap that is kept in the central sponsored schemes. That is suggestion one. And secondly, ma'am, is that we would request if there could be a little more than just the financial support, because the finances is just one part of how we can perhaps progress and improve our health structure, including the allied services. But what is primarily required in especially state like Odisha is the technical support that comes along. And to give you an example of what are the kind of technical support that one would expect and would be really grateful for, is number one, regulation and quality standardization across different disciplines and service provision. So how is it that one can look for technical support in this regard would be number one. And similarly, to give you another example, right now, the way even with the credit framework, what happens in existing courses is that they tend to get stagnated over a period of time. So let's say we introduce a particular course in 2026, but the requirement and the technology has transformed over a period of next 5 years. But what we do primarily is we do just minor modifications and tweaking in terms of provision of TOTs. But we don't look at how the course itself can be transformed with the current or the future emergence of new trends and technologies. So how is it that when we are starting a course, not just we can also take care of the stagnation part and have a transformative pathway for each of these courses? How is it that one can do that? I think states are at the moment ill-equipped to handle such kind of understanding. Perhaps a technical support in this regard would also could also be part of the central assistance that was given. So that is something that we would look for. Again, many of the earlier panelists did speak about moving away from a doctor-centric systems. In fact, in the Vision 2036 that the Odisha government has recently unveiled, moving away from a doctor-centric to a team-centric system is mentioned as one of the cornerstones of our health vertical that is there as part of our Vision 2036. Now, for moving there, in fact, there are certain requirements. I would say that it's heartening to see how central government is encouraging us to strengthen the existing medical colleges as an ecosystem wherein it would be developed as a comprehensive provision, a space where provision of not just medical education, but allied sector, paramedics, everything is provided. So this reorientation is something that is really heartening for us. Since that kind of an encouragement is coming from the government of India, it is easier for us to also navigate within the state political economy in that sense. So that is something that we really appreciate. And given that structure, I feel wherein the sharing of resources is very much possible, not just in terms of infrastructure, but even in terms of other resources, in even skill labs, technical orientation, and even training of our existing teaching tutorial kind of ecosystem, and also training to the future medical and paramedical and allied providers. So this is something that we would really like to take forward. So these are some of the asks from the state government, if I can put it that way now. And once again, I'm extremely grateful for the opportunity and really privileged to be part of this esteemed panel. Thank you, sir.
Thank you so much, Ashwati, for sharing us the state perspective. And it was also good to know, like, what are the challenges that Odisha has in terms of its demographic, disease profile, and because this will vary from state to state. However, the cornerstone for delivering healthcare would remain same. So that and the shift also that we are seeing to a team centric approach for healthcare delivery is, I think, which is really appreciable, because I see that when you mentioned that you've already brought in it as a part of your 2036 vision statement that you have released, that means so we are all aligned towards that. And I think this budget announcement has also come at the right time so that we can give it the right push. And another important point that you made was regarding the utilization of the existing. For example, we have these two schemes where with the existing district level hospitals, we have given assistance for medical as well as nursing colleges. So if you want to build a whole ecosystem, and when we are talking about these integration that Dr. Sheth was also talking about at the UD level, it might be a good idea maybe to have in the same campus or this level maybe allied healthcare courses to begin with. So that's a good takeaway for us, and also to see that the states are also thinking along these lines. Thank you very much for sharing your views on this. But one point which has come out very clearly in the discussions that we have been having since morning is that it's the private sector which plays a very important role in this allied healthcare education. Around 67 to 70%, I think, is the capacity lies in the private sector. So, however, at the same time, one question which gets asked is related to the affordability of the education which is being imparted by the private institutions, because it is generally thought that government education institutions, the fees are limited and it is more affordable. So, in this context, I would like to bring in Dr. Jagdishwaran Ji, who is Dean Allied Health Sciences, SRM Medical College. And I would like to understand from you, Dr. Jagdishwaran, that how can we ensure affordability and quality of allied healthcare education in private sector, in private allied healthcare institutions. I would like you to give your views on that point.
Respected Dr. Vinod Kotwal, ma'am, respected Chairperson, Dr. Yagna, ma'am, distinguished panelists, esteemed participants, good afternoon to one and all. At the outset, I'd like to extend my sincere thanks to the Ministry and the Commission for providing this important platform to discuss the critical issue of the future of healthcare delivery in India. The question is how we can ensure both affordability and quality in allied healthcare education, particularly in private sector. The key message was for the day is simple: affordability and quality in allied healthcare education, though look like a paradox, but are not opposing goal. In fact, with the right policy framework, they can be achieved simultaneously. To achieve this, we must focus on few strategic priorities that can enhance the affordability and quality in the AHP education. To start with, the first priority would be the smart and effective regulation for quality expansion. India needs a significant expansion of allied and healthcare workforce to meet the growing demand. And it has been deliberated that India, especially the private institutions, play a crucial role, and they currently contribute a substantial share of training capacity in allied health science across the country. However, while expansion is necessary, it also be guided by a strong regulatory framework to ensure patient quality, patient safety, while also avoiding excessive compliance burden that may increase the cost of education for the student. In this regard, the establishment of National Commission of Allied and Healthcare Profession is a landmark reform. The Commission, under its dynamic present leadership, is steadily bringing the structure, standardization, and professional recognition to the allied health sector. As institutions expand, strict adherence to the curriculum and regulatory framework is vital for the high quality and affordable education. Our regulatory philosophy should follow the principle of light but tight. Light in the procedure to reduce unnecessary costs, but tight in outcome to ensure quality, accountability, and public trust, and also to ensure patient safety. The second important priority is adopting a differentiated and geographically balanced approach to the institutional development. We all know that private institutions in India vary based on their infrastructure, especially we have large universities with advanced hospitals, with adequate research infrastructure, and we also have mid-sized colleges running allied health program with moderate resources and emerging institutions in the tier 2 and tier 3 cities and in rural India. At the same time, many of these advanced training programs primarily now concentrated in metropolitan area, leading to urban-rural imbalance in the healthcare workforce. So the uniform policy approach may not be much effective to address this need. Instead, a categorized, location-sensitive development strategy would be aligned with the National Commission, which can help to promote the quality and affordability. The larger institutions and high-performing institution can be designated as a center of excellence and as a mentoring hub based on the criteria as specified by the NCHP. Their role may include postgraduate and doctoral training, faculty development, mentoring emerging institutions, and providing access to advanced simulation laboratory and digital learning platform. Through a hub and spoke model, the universities can be an hub, whereas as a spoke, we can use the smaller institutions to share their specialized faculty, research facility, and high-cost training infrastructure. This strengthens the academic quality while also avoiding duplication of expensive infrastructure. And especially in the institutions which are coming up in Tier 2 and Tier 3 cities, where the funding remains a challenge, and there is also a huge regional workforce shortages. Policy support mechanisms such as viability gap funding, especially for installing the laboratory, simulation center, and the infrastructure can be considered. Public-private partnership with district hospitals, PHCs for clinical training, and especially the rural India, the centers, we need to incentivize for the institution to establish in underserved region. Such differentiated geospatial approach will expand the training capacity and also improve the regional workforce availability and also improve the affordability and also use of existing resources. And another and important or most foremost priority is improving the financial access for the student. Presently, one of the biggest barrier for the student face in our country is upfront financial burden of professional education. To address this, allied health education should be recognized as the priority sector for educational funding and financing. The possible mechanism can be the students can be provided with a collateral-free education loan, credit guarantee mechanism for banks, and interest subsidy scheme for economical weaker section. And as we are aware that we have a streamlined loan access platform called Honorable Prime Minister Vidya Lakshmi portal. So this portal, by the allied health program, especially the all recognized allied and healthcare program are clearly need to be mapped in this scholarship scheme. And another very important step is moving towards the affordability is better integration of allied and healthcare program within the national and state scholarship framework. These include scholarships which are currently offered under National Scholarship Portal as well as post-metric scholarship. And another important policy option which the ministry may consider is introduction of a dedicated central sector scholarship scheme for allied and healthcare students by the Ministry of Health. This scheme can be emulated by the model currently given by the Ministry of Education as center sector scheme for scholarship for college and university students. Such scheme will definitely expand the access of allied healthcare education, particularly from the students from the middle and lower income families. And there are few cross-cutting enablers which can strengthen both public and private institutions. To start with the strengthening of public and private collaboration for clinical training. Private institutions can be permitted to partner with the district hospital, public health care facilities under National Health Program to expand clinical training and internship opportunities. India already has a large network of healthcare facility across both public and private sector. In many ways, these represent as important dots in healthcare ecosystem. And the key requirement today is connect these dots through structured partnerships so that existing infrastructure is optimally utilized both service delivery and education. For an example, facilities developed under initiatives such as the Pradhan Mantri National Dialysis Program can be leveraged for clinical training and internship. And at the same time, as been deliberated earlier, there are many allied disciplines still have a limited sanctioned faculty position in the government institution, which restricts the overall academic ecosystem and opportunities for public-private academic collaboration. However, by sharing the clinical infrastructure rather than duplicating expensive facilities and with appropriate regulatory oversight, the structured training framework, this collaboration can significantly improve the quality of training, also keeping the allied education more affordable. And another important enabler, especially for private, would be leveraging the corporate social responsibility support to allied and healthcare education. CSR funding can contribute to scholarship for students, simulation laboratories, allied health skill development center, and clinical training infrastructure. Government may consider explicitly including allied healthcare education under the Schedule 7 of the Company Act, which will definitely help the student and encourage the greater corporate support for training infrastructure and allied health student scholarship under the CSR funding. And another important aspect, in addition to the our chairperson, Madam, what she has beautifully highlighted about the awareness generation strategies, I like to propose two initiatives. The one is the establishment of National Allied and Healthcare Professional Day. This one initiative should significantly create an awareness about the professional recognition among the allied health professionals. Currently, several individual professional organizations celebrate their own global observance day, and many allied health groups uniformly observe October 14th as the national day, but originally it is originated from United States. However, India does not have a national recognized day dedicated to all allied and healthcare professionals. Establishing the National Allied and Healthcare Professional Day from the ministry or from the government would further enhance the visibility of these professions among students, schools, and wider public. And second important initiative, along with the declaration of National Age, Allied and Healthcare Professional Day, the Government of India may also consider instituting national awards dedicated to allied and healthcare professionals, similar to Florence Nightingale Award for nurses and Dr. B.C. Roy Award for doctors. In addition, state governments may also consider instituting similar state-level awards to recognize the contribution for allied and healthcare professionals with their respective healthcare systems. This recognition will definitely will help in strengthening the professional identity of the allied healthcare professional, increase public awareness, motivate students towards the allied health profession, recognize the contribution, and encourage excellence, innovation, and professional standard. To conclude, ensuring the affordability and quality of allied healthcare education requires a systematic and a collaborative approach. And we need to give priority to smart regulation, differential geospatial institutional development, student financing reform, faculty capacity building, and strong public-private partnership. This will, if these measures are implemented in a coordinated manner, India can ensure that private allied healthcare institutions expand responsibly while maintaining both affordability and high educational standard. And this will not only strengthen healthcare delivery, but also enable India to meet the growing national and global demand for skilled allied healthcare professionals, which was the vision of our Honorable Prime Minister. Thank you once again for the opportunity. Thank you.
Thank you, Dr. Jagdishwaran, for bringing in a student's perspective when you spoke about, what can be done for increasing financial access for students to, join in these allied healthcare professions. This is one good point which you have brought in. And also, one common theme that I see, which is being highlighted by almost all the panelists, is the sharing of the current infrastructure that we have. So it's good to that instead of simply blindly creating new infrastructure, we utilize the existing that we have and create new wherever it is really required. Thank you so much for sharing your on how you think private sector can also deliver affordable and quality education to students, and bringing in some innovative ideas regarding CSR funding for the for allied healthcare professions. Now, we have been hearing a lot from the supply side. It's very important when we spoke about the demand side, when Shri Bhattacharya ji gave us the numbers across various professions that what we would be requiring in the next few years. At this point of time, it is very important to hear from the healthcare provider side that, what according to them can be the partnership avenues which are available in private sector for allied healthcare professions, students, training, employability of NCHP graduates aligned with India's evolving medical needs. So I would request Dr. Giver Gyaliji to share his view on this important point, because ultimately absorbing a lot of the students who are going to come out of the institution, the colleges that we are talking about, upgrading or creation. Dr. Gyani, the floor is open to you.
Madam, am I audible? Yes, please. Thank you very much. Now, let me start by saying that healthcare sector per se is supposed to be under regulation. In fact, we have been wondering for a number of years that where we have a regulatory commission for doctors, we have regulatory for the nurses, why there was no regulation for the allied healthcare professionals who are integral part of our health system and who are actually patient safety, they play the important role. But now, thankfully, I think commission has been put into place. And I would also like to quote what Dr. Sanjay was highlighting. The challenge is in front of Dr. Shukla that, this kind of structure at the national level to build and the time period, which is about 1.5 years or 1 year, is really going to be a challenge. And, but I'm sure, she will do the job. My advice has been that such commissions, the first and foremost requirement you have to keep in mind is the credibility. There have been few accrediting agencies in our country, where we have seen that the credibility is put into the question. So I think that should be uppermost in our mind. Dr. Abhijat Sheth was quoting, the NABH example. In fact, NABH is not really a regulatory body. In fact, purely a voluntary initiative. But today, it has got more than 25,000 hospitals either accredited or certified or impaneled, which actually have raised the bar on patient safety tremendously. So I think, and of course, another example I will quote is the National Board for Examination, where credibility is a hallmark for the number of years. I'm only quoting, few examples that Dr. Shukla can always, fall back on, how these institutions have come up and how, because any regulatory agency by its own resources will not be able to do the job, because how many employees you can have on the regular role. So you will have to depend on impaneled agencies and impaneled professionals. And how do we select them? How do we train them? And how do we keep eye on them will be the critical. Anyway, these are my few observations on this very aspect. Now, coming to the very specific question which Dr. Kotwal has asked, as a HPI. So on demand side, in 2022, we did a massive study and we actually quoted and submitted to the government. There were 2.1 million beds in our country at that point of time, 2.1 million, out of which 1.3 million beds were in the private sector and 0.9 million, that is 9 lakhs beds, were in the government sector. Of course, by this time, I'm sure the number must have gone by 15 to 20%. At the same time, population also has grown to that extent. But the important aspect which we brought was that more than 80% of the tertiary care beds out of this 2.1 million beds were in the private sector. And I think there I'm quoting Dr. Anurag, and that for training the high-tech professionals among the job roles, 11 job roles which have been identified by the ministry, you will need the services of these specialist hospitals, that is tertiary care hospital. So obviously it is inevitable that we engage the private sector into this very initiative, and of course we are all there to work with the government. There is no going back on this issue. So what actually my friend from NetHealth was quoting the total number. So I am quoting a different perspective, that if there are 2.1 million beds in 2022, and as per WHO, you need 4 million beds to match the requirement of 3 beds per 1,000 population, that means there is going to be double the number of demand even from the present number. Okay, so I think that means there's a hell of the number of the demand is available. Then we have nothing to worry on this very aspect. Now, coming to our you see, for example, in any hospital scenario, around 10 to 15% number is by the doctors, around 35% number is from the nurses, but the remaining 45% constitute the allied and support services. So even if I delete the support services from, like, let us say, the security and housekeeping, still there is a good 30% of the manpower which will fall in the category of the allied healthcare professionals. I think this is a huge number. So, in fact, what comes to my mind is, while the commission will be training, setting up the standard, setting up the certification norms in time to come, but what will happen to the existing number? Let me just quote one simple example. General duty assistant is one of the major job role in our industry, general duty assistant. And I should have no hesitation in telling people here that more than 90% of the existing general duty assistant who work hand in hand with the nursing staff are not certified. They are put in the hospital from the private contractors. Some of them may have some little experience or exposure, and some may be fresh. And they are just put into work with the nursing staff and directly dealing with the patient. So, in fact, the challenge in front of the ministry, I am saying, not commission, rather the ministry will be that how do we upskill and recertify, or rather certify these existing lot. That itself should be a parallel, I think, stream which will be taken up. In fact, there we have little experience, I will say, because I remember during COVID time, under the Prime Minister initiative, there was the frontline COVID worker requirement. And I think luckily HPI was the only body at that point of time who trained 3,000 COVID frontline workers in our country. Later on, for the geriatric care, we trained 1,200 under the Prime Minister Kaushal Vikas Yojana, because we are empaneled training partner with the National Skill Development Corporation. In fact, a couple of months back, there was a requirement of training the general duty assistant, and we collected more than 20,000 letter of intent from the existing or the new candidates to be trained as general duty assistant. However, that scheme for the time being is under the suspension. So what I'm trying to say, that HPI, with its 21,000 hospitals as members, we already have 60 impaneled training institution, which we are using, number one. Number two, we have 750 NBE accredited or impaneled hospitals as our members, and they are the best resource for training, like medical colleges. So they are also available to us. When I am saying available to us, they are available to the commission, they are available to the ministry. So this is a ready resource which we should be utilizing in training, more importantly for the high-tech job, profiles or job frames, So in short, I am only again and again saying that this is a challenging task, but we have the existing resources in government and in the private sector. Private sector, as I said, has got little bit advantage in terms of the tertiary care kind of things. Otherwise, government also has its own institutions and the district hospitals, medical colleges together. And that is why I think I'm very happy that in this panel, we have got mix of the private, mix of the government sector, and we are determined, all of us are determined to make this a huge success out of it. And we are available to the ministry, we are available to the commission with our, the advantage, which I'm quoting of HPI is that 21,000 hospitals, but scattered through the 20 chapters. So that structure actually makes us very important, because healthcare in many ways also is part of the state subject. So we work through that. So with that, madam, I will just close at this point of time, and subsequent questions I'll be able to answer. Thank you very much.
Thank you, Dr. Gyani, for giving us a perspective from the hospital provider side. And I think it's a very valid point that you made regarding the existing workforce which is there. What is the career pathway that we will have to think about them? Thank you for bringing out that point during your interventions. Dr. Vishwan, in his, when he was talking about involving the private sector, also talked about PPP models which can be looked into by the government for scaling up and rolling out this initiative which has been announced. So at this point of time, I would like to bring in Rahul into the discussion because from the Department of Economic Affairs perspective and his experience as Director Infrastructure, who's looking after infrastructure projects in the ministry. So I have a question related to, he has heard the whole spectrum of discussion that we have been having. I kept him at the end deliberately because I wanted him to get a flavor of the sector that we're talking about, and so that with his experience, he can tell us that what are the PPP models that can be adopted for establishing and strengthening AHP facilities in India, and can these PPP models be financially viable and attractive from private participation? Rahul, I give the floor to you.
Okay, ma'am. Am I audible, ma'am?
Can you increase your volume?
No? Now?
Yeah, I can hear you, but I can still hear the volume slow. What about other panelists? Can you hear him
Yes,
clearly?
yes.
It's little
No
low,
one.
right? Very low volume. You will have to increase the volume now.
Hello? Now?
Little better, but it can be increased.
Am I the maximum? Maybe
Can you do something? Can we do something from our side here? इनका बढ़ा सकते हैं? हमने अपनी व्यू से पूरा किया हुआ है. और करिए. Rahul, now speak, please.
Yes, ma'am.
It's better now. I can hear. Can others also hear?
Hello.
Little better.
Okay. Speak little loudly and well.
Okay, ma'am. Thank you,
And
ma'am.
then-
Apologies for this glitch. First of all, good afternoon to all. Let me take this opportunity to express my gratitude to be part of such an esteemed and august gathering. So, what I will be doing, I will be talking about the pillar one, because what I've heard in the last 1.5 years, the pillar one relates to infrastructure.
Audible.
Hello, am I not audible?
Yes, now you are audible.
Uh, I can hear him. I can hear him. You can't hear him at all.
Very low voice. I mean,
Okay. Rahul, I think I can still hear you, but I think it's very low voice. Can you come near to the mic?
Hello, now?
Is it better now?
yes.
I see thumbs up from Dr. Yeah, it's better now.
Okay, thank you. Okay, so I was talking about that. I will be talking about the pillar one, that is the infrastructure, because in the last 1.5 hours, what I have gathered, there's a dearth of infrastructure and how we can basically come up with alternatives to scale up the infrastructure. So in my intervention in today's session, I will be touching base on 6 important things. I will be talking about why PPP is needed. What is PPP? That is very important to understand what is PPP, because people often basically think PPP is similar to EPC, that the government provides land and then there's no role and responsibility of the government. So we need to understand what is PPP. Then I will be talking about whether these kind of sectors, which basically where the revenues or the are basically cannot be increased to such an extent. So the user fees, I think I'm having problem again with the volume.
Yes.
We can hear you. Please go ahead.
Okay, so yes, I will be talking about whether these kind of a sectors or the social sectors where the user fees are levied. So whether they can be undertaken on PPP or not, and then what are the models which can be used both for brownfield and for greenfield, and then I will be talking about the caveats because it's very easy to understand. I mean, say that I wanted to take this infrastructure project on PPP, but there are a lot of caveats which we need to consider it. And then these caveats are much more important when you're talking about PPP project in the social sector or a sector which does not have a proper market determined revenue. Then I will also be talking about lastly about the VGF, how VGF can be used as an instrument to make a social desirable PPP project, but which is commercially unviable, viable. So these are the 6 points which I will be talking about. So I will talk what is PPP. I mean, if you look at the economic discourses, there are various factors which can be attributed as to why we need PPP. But two important factors which stand tall is that it basically crowd in the private capital, and the secondly it also bring in what we known as the private efficiencies in operation and management of the asset. The second thing is that what is PPP? Now the PPP is basically a long-term contract between a government and a private entity, and the bedrock for this contract is basically risk allocation. So the risk has to be allocated to the party which are best suited to it. So most of the times, what I have seen that in a PPP, the government say, okay, we will be providing the land, and the rest risk you take. But then, I mean, in a sector which does not have a user, which have a user fee, so they cannot increase the fee to a very large extent. There, the private player also have a revenue risk. So therefore, the other party, that's the government, needs to basically come in into the picture and needs to help the private player in order to bear this risk. So the bedrock of a PPP is a proper risk allocation where the risks are allocated to the parties which are best suited. And then if there's a problem, then both the parties have to come up with a solution. Then the third question comes whether these sectors can be undertaken on PPP. Yes, these sectors can be undertaken on PPP. What are the models? In my experiences, there are 3 models. So basically, these models can be segregated for brownfield and for greenfield infrastructure. For brownfield infrastructure, you have a model known as OMDA, that is Operation Management Development Agreement. So this OMDA model is very much prevalent in airports. For greenfield, there are 2 models. The first is DB4 and the second is DB2. DB4 stands for Design, Build, Finance, Operate, and Transfer, whereas DB4 stands for Design, Build, Finance, Operate, and Own. The difference between DB4 and DB2 is that in DB4, the asset has to be given back by the private player to the government at the end of the concession period. In DB4, there is no such transfer of the asset. DB4 is much more prevalent in silos, food silos. And DB4 basically in hospital, in integrated solid waste management. So these are the sectors where DB4 model is more prevalent. Now coming to, okay, deciding to have a project on PPP is one, but then there are certain caveats which needs to be looked in. The biggest caveat or the biggest factor which you have to consider, because you are providing a concessionaire, I mean a concession to the private party for 30 years, for 20 years to build an asset. So therefore you need to come up with the projections, the revenue projections. So when you have an asset like training centers, or when you have a project like metro or hospitals, as a matter of fact, so therefore there you have to come up with some alternative scenarios in order to ensure that the revenue which is needed for operating this asset is not hampered in any way. So I will give you two examples. In hospitals, basically, what we are doing that 50% of the beds are for BPL and 50% beds are basically are market determined. So the private players have the flexibility of using those 50% beds rented out on a market determined uh, prices. However, the 50% of the bed, the rest one is basically for the BPL, and then they have to basically provide it to the government as per their insurance scheme. Similarly, in metro, for example, because here also the user fee cannot be extended or cannot be increased to such an extent, because then there will be a problem of excludability. You are excluding people from using the metro. So therefore, in order to make it more viable, what the PSA has done, that they have provided an alternative land near the metro station, which can be used by the private player for commercial or retail businesses. So therefore, they will cross subsidize the earning from there to in a running of the metro. So this is one way of doing it. Now when all these basically possible structuring is done, and then once find out that despite having all those things, the project is not viable, then you can have the viability gap funding. So viability gap funding is the last resort. So the first, if you wanted to undertake PPP, it should be proper structuring where you cross subsidize or you provide some alternative ways of ensuring the revenue. And if all those are not able to make a social desirable project commercially viable, then you can come to VGF. So in VGF, I can talk about the VGF scheme, which is administrative by the Department of Economic Affairs. So here we basically there are three levels of VGF which we provide depending upon the sector in which the project is undertaken. So if you have an economic sector, so the maximum VGF which can be given is 40% of the total project cost. If it's economics, if it's a social sector, then it can be 60% of the total project cost, and this amount is given during the construction period. So that it gives a little bit relief to the private player, so they do not have to infuse the equity, the total. And then the last one is basically 80%. However, the projects in this category is limited only for pilot projects in education and health sector. So in this category, we provide 80% of the TPC during the construction, and also we provide 50% of the O&M in the first 5 years. So this is, this category, the category third, which I've talked about, is basically for pilot project in education and hospital sector. With that, I think I have already, talked about all the 6 points which I wanted to make in this intervention. And with that, I will hand it over to ma'am, and I will be happy if there are any questions.
Thank you, Rahul, for your, giving us an overview of the PPP models which are there when you spoke about the OMDA model, which talks about operations, management, and development agreement. And then you also spoke about DBFOT, which is the design, build, finance, operate, and transfer. And lastly, you spoke about your design, build, finance, own, and operate DBFOT models. So we got an overall perspective on how the PPP models, because health is a social sector, unlike infrastructure. A sector where the PPP models would be a little different. So here we would have to think maybe a little differently within the frameworks that you have mentioned to us. And then we also spoke about if the projects are not viable, how we have to bring in viability gap funding, these aspects also were touched upon by you. So with this, we come to the, I would say, the kind of it's fruitful discussion that we have been having since morning. And thanks a lot to all of you for being so patient, and hearing each other out. For me personally, it was very enriching to share all of you together and to gain insights from private, public, all aspects, regulators. So if I had to, kind of sum up, it would, in 5 minutes, it would not do justice to the enriching discussions that we would be having. Just to, from what I have understood, the key themes on which we discussed since morning were around regulatory framework, workforce demand assessment, the private sector partnerships that we can have, the need for stakeholder consultation, the operational strategies that we need to have for rolling out what we have talked about. And the most important point, which has come across in interventions by most of you, is that we need to have these partnership models between educational institutions, hospitals, so that we are able to lay the foundation of the three pillars that we have of infrastructure, clinical material, and the faculty. So as a way forward, what I could hear was that maybe there would be a need to focus on faculty development and look at faculty requirement from a holistic purpose, and also maybe bring some sustainable regulatory reforms on certain points. Then Dr. Sheikh also talked about digital learning integration that we need to bring in if we want to reach that scale. And the point which came again and again was the infrastructure optimization. How we need to optimize the infrastructure that we have in terms of shared laboratories, digital resources, a partnership with hospitals, and even sharing of faculty. Whether we can have visiting faculty, we can have preclinical subjects being taught by doctors who are teaching the medical students. And also, another important point which was there and which was very heartening for me was the hospitals are willing to collaborate in this. Because if you see all the courses that we are working on are very skill-based courses which require good clinical material for our students to learn. So collaboration with the health care partnership is important, and because it gives them an opportunity for internships, enhancing their skills. So, that interaction would definitely help. And I remember Dr. Jagdishwaran also talking about the spatial planning that we need to do. Tier 1, Tier 2 cities, then the rural versus urban, because the requirements, and I think Dr. Shahi also spoke about that example of the requirement of a robotic surgery and a cardiothoracic labs, which may not be available at a Tier 2 or a Tier 3 city, but it may be available at a tertiary care hospital level. So all these complex inputs which were given will definitely help us in working out towards a more clearer strategy. That's what these discussions are meant for. And then also, Dr. Gandhi also talked about a strong accreditation mechanism, which are very good examples of NBH, which is not a regulator, but has got a very strong, I would say, quality stamp on the hospitals which are there. So all these. At the same time, what NCHP has been doing in terms of building this one nation, one curriculum task, which is Herculean, and I must compliment Chairman NCHP for her leadership in navigating this difficult area. It's not easy. We need to understand this was an area which was unregulated till 2 years back, bringing everyone into this regulatory fold and then laying down standards and norms. And it's not easy. So my compliments to you, ma'am, for navigating this difficult area in this very important because Dr. Gandhi said, I was wondering that why did this commission not come earlier? It should have been there when we had the medical and the nursing and the dental and the pharmacy education such. So it's right that the government has brought in this commission and which is doing its job wonderfully. As they say, it's the resources which make the world go. Without resources, nothing will happen. So in the end, it was very nice to hear from Rahul that what are the various options which are available to us so far as PPP models are concerned. Because as you know, and as we have seen, most of the capacity is currently in private sector. So if we roll out any scheme or any initiative, we need to bring up the private sector also in this, because it's a joint responsibility. It's not that it's only the government's job or the private sector's job. You have to work together. And we have to design schemes or initiatives or interventions which will work together for all of us. So I think we have got a lot of insights, and I'm sure over a period of next few days, we will be interacting with you much more, and maybe broaden our stakeholder consultation also. But my heartfelt thanks to all of you for being such patient panelists and giving such excellent inputs, which will help us in designing our schemes and operationalizing the budget announcement which was made, which will we hope in the coming years. People should remember this budget announcement as the pivot which changed the allied healthcare professions. That should be our goal, and we are very happy to work with all of you. Thank you again for your patience and for your inputs. Thank you and namaskar.
Thank you so much, madam. Thank you.
Thank you.
क्विट करूंगा, हितांशु क्विट करेंगे, बंद करेंगे।
शायद वापस 3 बजे ज्वाइन करना
हाँ 3 बजे तो ज्वाइन करना है।
है।